Hello and happy homecoming. I am Adrienne Powell, Director of Alumni Engagement. While I would prefer to welcome you back to campus, I hope you have enjoyed the virtual programming this week. Back to college classes are an important tradition at Illinois Wesleyan Homecoming, and we are thrilled to be able to offer so much wonderful content from the Titan community. Today is TGOE Day, which, in case you are wondering, stands for Titan Green over everything. I hope you are wearing your Titan Green, and I hope you have found ways to connect to your former roommates and professors and reminisce about your time at Illinois Wesleyan. And now about this Back to College class. We welcome your participation through the chat function at the bottom of your screen, and we will get to as many questions as we can. Along with all of the homecoming events, this will be recorded for viewing at a later time and posted on the IWU Alumni Association YouTube account. Please subscribe to that in order to be notified as new episodes are added. We are honored to welcome Dr. Todd Gudowski as our speaker today. Thank you for taking your time out of your busy schedule to teach us about your work. I'm joined by Professor Given Harper. He is the George C. and Ella Beach Lewis Endowed Chair of Biology. Dr. Harper is an ecologist with diverse research interests. He's currently supervising students who are investigating the distribution and habitat preferences of American badgers and plains pocket gophers in McLean County. In addition, he is supervising students who are determining the species of breeding birds and their habitat preferences within the city limits of Bloomington Normal. Dr. Harper, I will hand it off to you so you can introduce Dr. Gudowski. Thanks so much.
Well, good morning, and I'm very happy to be here. So our speaker today is Dr. Todd Gudowski, and he graduated from Illinois Wesleyan in 1995 as a double biology and history major. And I think perhaps one of my fondest memories of Todd was when he was a student in my marine biology course in Australia during what was then our January term. And for 2 weeks, we stayed at a research station and snorkeled daily along the exquisite Great Barrier Reef. And I suspect Todd remembers, I certainly do, of swimming over 3-foot-long giant clams. Todd and his classmates documented over 300 species of fish, many of which had very dazzling colors. And I think experiences such as these are truly opportunities of a lifetime for our students. So I'll give you a brief biography of Todd. After graduating from Illinois Wesleyan, he completed his MD at Loyola University Stritch School of Medicine. Todd then completed his residency in pediatric internal medicine at Indiana University. And he then had an opportunity to provide health care for a 2-month stint in Kenya. Todd indicated that his experience there had a lasting impact on how he practices medicine today. So Todd then completed a fellowship in pediatric cardiology at Cincinnati Children's Hospital. And today, he is one of only 4 pediatric congenital interventional cardiologists in his home state of Wisconsin. So we're delighted to have him speak, and the title of his presentation is Saving Children's Lives, an insider's look into the work of a pediatric congenital interventional cardiologist. And then at the end, we'll have time for questions. So Todd, welcome back to campus, at least from a virtual perspective.
Thank you very much, Given. I appreciate that. And I am too disappointed not to be back on campus to give this lecture, but I'm excited to be able to share a little bit of what I do and then talk a little bit about healthcare in our country as we move through our talk today. So thank you for coming. I do have a few disclosures. I am a proctor for Abbott Medical and teach other physicians how to use a few of their devices around the country. And I have done some consulting work for Medtronic in the past. What I wanted to start with today, and before I talk about my journey to become a doctor who cares for infants, children, and adults born with congenital heart disease, I wanted to share some background information about congenital heart disease and the patients and families it affects. I borrowed this slide from an organization called Conquering Congenital Heart Disease, and I think it's very powerful and a great launching point for our discussion this morning. Congenital heart disease is the #1 birth defect and affects 1 in 100 newborn infants in the United States and around the world. Many infants are born with very severe forms of congenital heart disease, and even today, it is the #1 cause of birth defect-related deaths in the United States. Roughly 40,000 infants are born with various forms of congenital heart disease every year in the United States, and most required specialized care throughout their lives. Fortunately, over the past 80 years, medical progress has been extraordinary, and most infants and children today undergo successful surgical or interventional procedures to treat their heart disease and survive to adulthood. There are now well over 3 million adult survivors of congenital heart disease living in the US today, and this number continues to grow. As a pediatric congenital interventional cardiologist, I'm one of about 175 super specialized physicians in the United States that has the opportunity to offer non-surgical catheterization-based treatments to these patients. These treatments include life-saving procedures such as emergency balloon atrial septostomies and balloon dilation of critically stenotic aortic and pulmonary valves in hours-old infants, as well as device closure of holes in the heart, and even non-surgical insertion of new heart valves into the heart. This is truly amazing work at the cutting edge of medicine, and I'm grateful my career has allowed me to contribute to this field and to care for so many patients along the way. This is a picture of our Cath Lab, myself with one of my radiology technologist assistants, Karen, while we're doing a procedure, just to give you a sense of the room I work in, or one of the rooms I work in. So before we talk more about congenital heart disease and interventional therapies, I wanted to pause just for a few minutes to talk about my journey and how I came to become a physician and then a pediatric interventional cardiologist. So my journey started at Illinois Wesleyan 29 years ago this fall. I cannot believe it's been that long. Here I had great teachers in the biology department who demanded a lot, but really cared about their students' success and my success. I remember Dr. Bruce Riley giving the first lecture in General Biology 101 and the expectations he set for the entire class. I was then again fascinated in my junior year in embryology, and his lectures on heart development are still some of the best that I've ever had. And I've had a lot of lectures on the embryology and development of the heart in my career. I remember Bob Hiptonsteel, and the way he taught physiology really sparked my curiosity for the human body and how everything works. And then I remember this guy, Given Harper, who was crazy enough to take a group of 21-year-old students halfway around the world to Australia to study marine biology on the Great Barrier Reef. This is an experience that I've never forgotten and was just absolutely amazing. And the type of experience that I chose Illinois Wesleyan for 29 years ago. After my time at Illinois Wesleyan, I moved on to Loyola Medical School, where I had the chance to work with Drs. Frank Setta and Dr. Bob Lichtenberg, who were med-peds physicians, as I am, and pediatric and adult cardiologists, respectively. And they worked with kids and adults with congenital heart disease. And I was able to watch my first pediatric heart catheterization by Dr. Setta and was absolutely fascinated, just blown away. It was while I was in medical school, though, that I had a personal experience and that Jack was born. He was a close family friend, and he was born with severe congenital heart disease. He was actually the second child born to this family with severe congenital heart disease. The first had passed away at a few days of age after unsuccessful surgery. His family's experiences and my experience helping them navigate the world of congenital heart disease and medical care really sparked a deep interest in congenital heart disease in me, and was really one of the paramount kind of sentinel events in my life that pushed me towards congenital heart disease and becoming a pediatric cardiologist. After I left Loyola, I moved on to Indiana University, where I became a resident in internal medicine and pediatrics. It was at IU that I was able to explore my interest in congenital heart disease more, and Dr. Mark Hoyer let me observe in the Cath Lab, and Dr. Roger Hurwitz let me attend his adult congenital heart disease clinic on a regular basis. I also had a unique opportunity to spend 2 months in Eldoret, Kenya, working on the peds and medicine wards at Moi University Hospital with Dr. Joe Manlin. He and I spent one afternoon every week seeing congenital heart disease patients in his clinic, and the experience was life-changing. I was able to see just amazing group of people, an amazing group of physicians work in situations that were at times, very desperate, but the amount of care that we were able to provide, particularly in the middle of the HIV and AIDS epidemic, was amazing. The lack of healthcare, or the lack of access to healthcare for many Kenyans, was eye-opening though, and continues to shape my thoughts on how we provide care in the United States today. After I finished my time at IU, I moved on to Cincinnati Children's Hospital, where I worked with my mentors in congenital heart catheterization, Dr. Robert Beekman and Dr. Russell Hirsch. They taught me how to perform many of the procedures I do today and gave me a foundation to learn many of the new procedures as our field of interventional cardiology has advanced. Currently, I've been practicing at the Children's Hospital of Wisconsin as a pediatric congenital interventional cardiologist since 2008. I've performed more than 2,000 congenital heart catheterizations on patients aged 30 minutes to 75 years old. What I've learned along the way is that education and training are all about the people and teachers you have a chance to meet and learn from and share experiences with. I'm grateful for all of my many teachers and mentors that have helped to shape my career. I wanted to start today first talking about what exactly is a heart catheterization. I have the sense that not necessarily everybody knows, and what it is it's a minimally invasive procedure where small tubes or catheters are inserted into the veins and arteries, or both, and advanced into the heart. And we can insert these catheters into typically the veins and arteries of the leg, but often the arm or the neck, really wherever we can get a needle into a blood vessel. Blood pressure in the veins, arteries, and in the heart chambers are measured and recorded, and contrast dye can be injected through the catheters to visualize the cardiac chambers, the large arteries, and veins by fluoroscopy. The procedure was first described and performed on himself by Dr. Werner Forstmann in Germany in 1929. So if you think about that for a minute, that's less than 90 years ago was the first heart catheterization described. And as I think about what I do today, it's amazing the progress that has happened in under 100 years. So what is a congenital interventional heart catheterization? This is a heart catheterization intended to perform some form of therapeutic procedure, and that could include an atrial or ventricular septal defect closure. So those are holes in the heart that could be closed by a variety of devices that have been developed. Transcatheter pulmonary valve insertion, potentially aortic valve catheter insertion, or aortic valve insertion, I should say. Patent ductus arteriosus closure, pulmonary artery or aortic balloon angioplasty or stenting, and then pulmonary or aortic valve balloon dilation. So there are a lot of different things that we can do and a lot of different procedures to master. So how is interventional heart catheterization different from heart surgery? Well, with congenital heart surgery, that involves a sternotomy and an incision to access the heart. And what I mean by sternotomy is making an incision and then cutting through the breastbone so that the chest can be opened and the heart exposed. Oftentimes, the heart needs to be stopped for the operation so that the surgeon can operate on the heart. It's very difficult to operate on a beating heart. And so cardiopulmonary bypass machine is utilized so that when the heart is stopped, blood can still be circulated and oxygenated so that the patient can continue to live. Oftentimes, because of inflammation and some bleeding after surgery, drains have to be placed around the heart and lungs so that fluid can exit the chest for the next 48 or so hours and not cause a life-threatening complication called cardiac tamponade. Often patients need to be hospitalized for 1 to 2 weeks after heart surgery, and it often takes them about 6 weeks or so before they're ready to return to school or work. So it's a very big deal. And congenital heart surgery is an important treatment that is offered to most, if not all of our patients at some point. Congenital interventional cath, though, differs in significant ways. For congenital interventional cath, no incision is required. The entire procedure is performed through needle punctures in the neck or the groin, and all that is required is to recover from these small needle punctures, which usually takes just a few days. The heart's beating for the entire procedure, so there's no need for cardiopulmonary bypass. Typically, patients just need to stay overnight in the hospital, and they can often return to school or work in 2 days. So very, very rapid recovery, even with our most invasive and our most difficult procedures. What I wanted to do was go through a few examples of what a heart catheterization looks like and share a little bit of information about what it is that I do. So this first year, if I can get my movie to play. My movie seems to be a little bit stuck, which is a little bit of a bummer. Let me see if I can do this for a second. So it won't work quite as smoothly, unfortunately, but this is an example of an aortic coarctation. And so this is an angiogram taken in the straight AP projection showing the aortic arch and coarctation. And a coarctation is this narrowing in the lumen of the vessel. And this can cause hypertension in the ascending aorta and then poor blood flow in the descending aorta. And this can be treated non-invasively through heart catheterization. And so what that involves and looks like is a balloon with a stent mounted on the balloon can be deployed into the descending aorta at the area of narrowing, and that can completely relieve the narrowing. And this is an example of what a stent looks like when it's being deployed. And then a follow-up angiogram Oops. looks like this. So we have the stents in place, and the coarctation narrowing is now completely relieved. And all of this is done through a small incision in the femoral artery, with the patient recovering overnight in the hospital and discharged home the next day. So amazing, amazing procedure that has really revolutionized the way that patients with coarctation are treated. So we'll bounce back and forth between my presentation and a few of the videos. I apologize that the videos aren't running as well as I had hoped they would. So again, what a coarc stent would look like, the ballooning, and then our results at the end. Another type of procedure that I can perform is PDA device closure in small, tiny preemies. So just a year ago in January of 2019, the FDA approved the first ever device to close patent ductus arteriosus in premature infants. This device is the Abbott Piccolo occluder and has been really revolutionized the way that we treat our smallest infants with ductus arteriosus. About 20% of infants born under 28 weeks gestation have this blood vessel that persists called the ductus arteriosus. It's very important in embryologic fetal life when babies are in the womb and not needing to circulate blood to their lungs, but it can cause severe forms of heart failure for our tiniest infants. And traditionally, all that we could offer them was surgery to close the ductus arteriosus, which often caused the patients to get quite ill. And our neonatologists would often be reluctant to refer patients for surgery because it would make them so ill. So at a point where the treatment was often worse than the disease itself. With the advent of this device, we were finally able to offer PDA device closure to our smallest patients, patients in fact as small as 700 grams, which is just a little over a pound. Prior to this, the smallest patients we could offer PDA closure to were about 7 to 8 pounds. So this was an amazing breakthrough in my field. I never thought that I would be offering heart catheterization treatments to a 1 pound premature infant. It absolutely boggles my mind. But over the last year, I've learned how to do this procedure and actually now teach several other physicians on a regular basis how to do this procedure. And we're able to now close PDA. So this is what an echocardiogram of a large PDA looks like. This is the ductus arteriosus. This is color flow through the ductus arteriosus. The red flow is flow that's going backwards from the aorta into the pulmonary arteries and is abnormal. And what I'm able to do is position a device into the ductus arteriosus and close the PDA. Those will be a little bit harder to locate, so I'm not going to be able to quite show that as easily as I wanted to. So let me go back and we'll look at the still images. And I apologize again that my videos didn't want to work today. So the way that that looks is through a catheter, the device can be positioned within the ductus arteriosus. It can be seen on the ultrasound image right here. And these are the branch pulmonary arteries that if my image was playing, would show just blue flow through the branch pulmonary arteries and show this device to be in excellent position. Once the device is well positioned by ultrasound and fluoroscopic guidance, the device is then released from the delivery cable and stays in place. The last procedure I wanted to share with you, and I should be able to show you a few images of this, is a transcatheter pulmonary valve replacement. So many patients with congenital heart disease have surgical replacement of their pulmonary valves as infants or young children. Surgical valves only have a 5 to 10 year lifespan, and then they become dysfunctional, they become calcified, they stop working well. And so they either become narrowed or they become leaky or both. And then they present issues with the patients in the sense that they often develop symptoms of heart failure or at least exercise intolerance, which is unacceptable. And these patients typically or historically have required multiple surgical valve replacements over their lifetime. If you think of a 1 or 2 year old patient getting an artificial surgical valve, that could be 5, 6, or 7 heart operations in their lifetime, which is not unusual. But in 2010, the first transcatheter pulmonary valve was approved for use by the Food and Drug Administration. So what this means now is for our patients that are as young as 5 or even 6 years of age, rather than having to undergo repeat heart surgery where their chest is open and they spend a few weeks in the hospital and then a few weeks at home recovering, they can now have a new valve put inside their old valve in the Cath Lab, stay overnight in the hospital, and go home the very next day with a brand new valve that should last them another 5 or 10 years before they need to have the procedure repeated. So an amazing breakthrough for these patients. What I'm going to walk you through is just a few pictures of what that looks like. Just because I think that the images themselves are very, very interesting. See if I can find it. All right, so these will be a few images that I think will be good to see. So this is what a dysfunctional pulmonary valve looks like when we take an angiogram of it. So this is a very narrowed valve that is no longer functioning well and causing severe stenosis for this patient. And what we need to do first is balloon dilate the valve. So that we can see if we can do this one more time. Balloon dilate the valve. And that is what this looks like here, is with the balloon dilating the valve. After the valve is redilated, then we can actually then move on to placing the new valve into hopefully everybody can see this now. Is we can then place a series of stents and then the actual valve with, or the stent with the valve inserted in it into the pulmonary position. So we now have a valve here in the middle of the stent. You can't see the valve moving and closing, but you can see that no contrast now leaks into the right ventricle. And we now have a new competent pulmonary valve that was put in non-surgically and should last the patient another 5 or 10 years before the procedure needs to be repleted. Often, transcatheter pulmonary valves can be put in several times before surgical revision and replacement of the valve is necessary. So I think an amazing breakthrough for these patients. And now I would say we do a procedure like this for our patients about once a week, as opposed to them having surgery. And it's been an amazing breakthrough for those individuals, which I think is absolutely amazing and has been life-changing for them, as well as really life-changing for our program, as these patients now have the procedure performed in this manner. So a little bit. So we'll get back into my slide, and that'll be the end of my movies. I apologize, these didn't work as well as I had hoped. So what type of place can do procedures like this? Well, it turns out that this type of super specialized care takes an enormous team to deliver and is only available to a small number of large children's hospitals across the country. At our institution alone, we have 24 pediatric cardiologists, 3 congenital heart surgeons, 3 congenital interventional cardiologists, 11 pediatric cardiology or pediatric cardiac anesthesiologists, 5 pediatric critical care intensivists, 4 pediatric perfusionists. Those are the folks that put people on the heart-lung machine, and over 200 pediatric cardiac nurses. This is just for the cardiac program. This doesn't include our cystic fibrosis program, our cancer program. Our hospital, as are all children's hospital, is an absolutely amazing collection of very specialized physicians who perform this type of work. Our catheterization lab, we have 3 pediatric congenital interventional cardiologists, 1 physician assistant, 5 Cath Lab nurses, 5 Cath Lab radiology technicians, and 2 Cath Lab secretaries. These are a few pictures of our team. So this is myself with a few of our nurses and technicians, the very last day of our old Cath Lab before we built our new Cath Lab. This is another picture of my team and my partners. And then this is myself doing a procedure with Karen in our old catheterization lab. In 2019, we opened a new state-of-the-art catheterization suite at a cost of $4 million. It's the most expensive procedure and operating room in the entire hospital. So just one room with all the technology that we have in the room to perform our procedures. So think about that for a minute. But also think about what makes a children's hospital a little different. So in addition to caring for children, children have, in children developing illness, they have a bunch of other different needs that we need to support, including supporting the family. And so we have child life specialists that engage children in play and help them cope with pain and illness while they're here with us, and both as outpatients. We have music therapists. We have dedicated child-focused speech therapists, occupational therapists, and physical therapists. All of these are focused on kids, not adults, or they do kids and adults in combination. We use animal therapy. And then many children's hospitals have Ronald McDonald houses that help families that travel large distances stay with us, and stay with us for long periods of time at very low cost. 60% of our patients live outside of Milwaukee and travel more than 250 miles to receive care. Puts an enormous burden on them to, when their child is hospitalized for 2 or 3 weeks at a time, the financial impact of doing that is amazing. And at the Ronald McDonald House, which is right across the street from our hospital, they're able to stay for either $0 or less than $5 a day, and that includes 3 meals a day and a room to stay in. So it is amazing, and it removes that stress from parents that who have children that are often hospitalized for weeks at a time. But this care is not inexpensive. So when we talk about just the procedures that I do, a diagnostic heart catheterization costs $20,000. The coarctation stenting procedure I showed you cost $50,000. Preemie PDA device closure costs upwards of $100,000, and that doesn't include the patient stay in our neonatal intensive care unit. That's just myself doing the procedure and the cost of the care after the procedure for just a day. The transcatheter pulmonary valve implantation I showed you costs upwards of $150,000. So who pays this bill? Well, we have private insurers. Most are employer-based, but some are private citizens buy their own insurance, now made easier through healthcare.gov marketplace plans. The TRICARE health insurance for U.S. military. Then you have government insurers like Medicaid, which is health insurance for children, the poor, and the disabled. Medicare, which is health insurance for the elderly, the Veterans Administration. And then you have the uninsured. So when we look at U.S. health insurance coverage, I wanted to break down and just share this slide with you from the Census Bureau that talks about 2019 coverage. And we had an 8% uninsured rate in this country, with 92% of people having insurance. If you think of that $150,000 transcatheter pulmonary valve implantation without insurance, that type of care is unaffordable for most families. When we look at how insurance breaks down, 68% of people have private insurance. Most of those are provided through employers. 10% are purchased directly by consumers themselves. And then when we talk about public plans, we have a pretty even breakdown between Medicare and Medicaid. So not terrible, but most American citizens get their healthcare coverage through their employer. Typically, a children's hospital has 2 large payers, private insurance and Medicaid. So typically, most children's hospitals are around 50 to 55% private insurance and about 45 to 50% Medicaid. This is important because Medicaid reimbursement is often very poor and is often less than 5% of the hospital or physician charges. So going back to that example of $150,000 for a transcatheter valve, Medicaid would likely pay somewhere around $1,500 to $7,000 for that procedure. that doesn't even cover the cost of the heart valve itself, let alone all of the work that the physicians in the hospital do. So Medicaid is not a payer that hospitals can count on to provide sustainable health care to their patients. Typically, Medicare reimbursement is around 25 to 30% of hospital charges, and private insurance is around 45 to 65% of charges. So in a hospital system that 50% of their patients are Medicaid and really aren't able to reimburse the hospital or the physicians for the cost of their care, really the private insurance market bears the brunt of paying for most of the healthcare costs in this country. It's important to remember that Medicaid as a program, their expenses for children are typically less than 10% of annual Medicaid expenses. 90% of Medicaid expenses go to the elderly poor, often who are in hospitals or nursing homes at the end of their lives. So children receive very little or a very small number of the Medicaid market, despite children's hospitals having about half of their patients on Medicaid. So it puts children's hospitals in a very tenuous financial position. So the Medicaid program and the Affordable Care Act extended coverage to young adults to ensure nearly all children and young adults have health insurance coverage. So the Affordable Care Act allows children to remain on their parents' private insurance until the age of 26, and Medicaid is available to children with disabilities, poor children and mothers, and children are eligible to stay on Medicaid until the age of 19. The ability to extend Medicaid insurance coverage to most children in the U.S. ensures access to health care for most children. This is not the case for adults seeking health care. But one of the things to consider and to think about is that poor children with chronic health conditions often lose insurance at the age of 19 when they're no longer eligible for Medicaid. So this is a map of the U.S. uninsured rate, and you can see that really states range from less than 5% to 12 or more percent, and that particularly in the South, the uninsured rate approaches 9 to 12%. So our southern states have significant problems, more so than northern and Midwest states, with the uninsured. And this is becoming an increasing problem for these states, their citizens, and the healthcare industry, particularly hospitals and physicians. It's important to note that things are better than they used to be. The uninsured rate has really come down quite a bit since the Affordable Care Act was passed. So the Affordable Care Act was passed in 2010 and went into implementation kind of in 2011, 2012. And since then, the uninsured rate among particularly patients aged 19 to 64 has dramatically fallen. So we have done things to try to provide more insurance and more insurance coverage to families. But medical bankruptcy still remains an important problem. It's estimated to affect up to 500,000 American families in 2019. A recent survey by the Kaiser Family Foundation found that 4 in 10 Americans have had difficulty paying medical bills in the last year. So either had to delay them or not purchase other goods or services because of their medical bills. So one of the questions I wanted to leave our group with was, how should we continue to pay for healthcare in the United States? So advances in medical care will continue to deliver life-saving and life-extending care to patients at tremendous expense, as I have shown just in what it is that I do. The care I deliver as a pediatric congenital interventional cardiologist is an example of this tension in medicine. And I think for all of us to think about, and one of the things that I wanted to leave the group with today was, what do we do, and to recognize that we have choices and that we can impact that. And in the work that I do, as well as the work that everyone does, I think that this will be a question that we need to start to answer and answer more, as particularly in the face of a pandemic that has led to increases in unemployment, more and more patients and more families are starting to feel this pressure of how to pay for medical care, especially the type of medical care that I deliver. So with that, I wanted to end my talk and take any questions.
And yes, so participants can perhaps unmute themselves or ask questions through the chat. So I will actually start out with one. So Todd, so let's say that you would have the power, the czar to change healthcare delivery in this country. So what approach would you take to solve this issue?
So one of the points that I didn't make, but I will make now, is that when we think about healthcare and access to care, we've made the decision in this country that healthcare is a service that we purchase. And so healthcare and going to see the doctor and interacting with medical specialists is no different than getting a haircut or getting a massage. And that has, I think, what I would like to see is, I think that we should do better in this country, and that I think most physicians and most healthcare providers feel that healthcare and the right to get treatment when one is sick is more than just a purchased good or service. It's a fundamental human right, in my opinion. And so I feel that if we start from that point, then we can redesign our healthcare system and the way that we pay for it to reflect that that healthcare is a right. So what I would like to see is for our country and citizens in our country to say that, you know, everyone in this country deserves access to healthcare and healthcare providers, and the government in some way will ensure that that right is delivered upon, either through the private insurance market or through the government insurance market, however we want to do that. But I think that that's the basic tenet that we need to start with. And when I talk about how my opinions for healthcare were shaped, you know, I've spent time in a lot of countries across the world, but in two different ones that I spent time in, Kenya and Australia, we saw two different types of healthcare markets. In Australia, healthcare is a right, and every person in Australia is entitled to some level of healthcare regardless of their situation. In Kenya, I saw two different types of healthcare. I saw the healthcare that was delivered to the wealthy, which they have some very nice hospitals, and the wealthy could get a lot of care. But I also saw in the institution that I worked with, patients that lied across three in a bed. Patients were kept in the hospital intentionally until their families could pay for their care in some way, whether it was barter or money, and that patients were turned away from care or couldn't access care in the middle of the HIV/AIDS epidemic because they didn't have any money. And so the system that developed there was care for those who had money and care for those who didn't. And that was just absolutely devastating to watch, and really it has made me question, why is it that we do things the way we do in our country? We should be better than that. So I would start with that basic premise, Kevin.
I expect this will continue to be an issue, certainly. So we have several questions from the chat. So Kelly Wittich, what do you see as the most exciting research in the CHD pipeline?
I think that there are a few different areas that are exciting. I think first is that in my field, interventional cardiology, we're developing more and more transcatheter valve technology, and we're miniaturizing that more and more. So we'll be able to offer that to more patients, and we'll be able to do it through smaller percutaneous access sites, which means that we'll be able to offer it to smaller and smaller patients. We won't have to wait until patients are 5 or 6 or 10 years of age. We'll be able to offer it to them when they're 1 or 2. So I think that's very exciting. What's also exciting is we are getting closer to being able to manufacture and produce new heart valves and new heart tissues that are made of the patient's own cells. And so we're getting very close to, we already can build heart valves on a scaffold with stem cells from patients and make these valves somewhat functional. The technology isn't quite there, and the strength and the differentiation of the different tissues isn't quite good enough yet. But I think that in 10 years, with the path that we're on, we will be able to grow new heart valves that are better than the patient's original heart valve, and that will be able to be implanted either surgically or on a transcatheter platform. And then those valves should last a lifetime because they'll be living valve tissue as opposed to dead valve tissue or animal preserved valve tissue. The valve that I showed is a cow's jugular vein mounted on a stent. And these non-living tissues only survive for so long in the body. But once we're able to put a living native valve into the body, hopefully that will be a valve that grows and lives with the patients and will last much longer. So that's, I think, the most exciting development in our field right now.
Okay. Hiroshi H, the question, do stents and valves last the lifetime of the child, or do they need to be replaced as they grow up?
They need to be replaced as they grow up. So the stents and valves that we put in now last 5 to 10 years at most, sometimes much less, and they need to be replaced or made bigger. So if I put a stent in, let's say, an infant, I often will choose a stent that I can make bigger over time, and so we'll do a repeat procedure a year or 2 later as that infant grows to make the stent bigger. So requires many of these patients have to undergo procedure after procedure, either in the Cath Lab or surgically.
All right. We have a question from Lexi Trammell. Typically, how long do these procedures take? And also, I see you were a baseball fan by the picture in the back. Do you have a favorite team?
Yes, so my favorite team is the Cubs, who were unfortunately eliminated in the playoffs this year. I transitioned from a White Sox fan to a Cubs fan while I was at Illinois Wesleyan. So the basement of McGill Hall, watching a lot of Cubs games during the afternoon in between classes. The procedures themselves can take anywhere from about an hour to, let's say, close a hole in the atrial septum using an atrial septal device or using a PDA device to close the PDA, to 6 to 10 hours to do a transcatheter valve procedure, depending on how severely diseased the original valve is. It can take a long time to open up the old diseased valve and then get the what we call the landing zone, the area where we're going to put the new valve, big enough and secure enough to be ready to implant the valve. So, but most of our procedures are about 1 to 3 hours long.
And then finally, we have a question from Kelly Wittich. How do you feel about the availability of government funding for CHD research compared to other conditions? And how has that changed since COVID? And she also says, "Go Cubs," even eliminated.
So through organizations, through the American Heart Association, the Pediatric Heart Network, organizations like Conquering Congenital Heart Disease, they have done very, very good jobs, and I should say the American College of Cardiology have done very good jobs of lobbying Congress for funding that is dedicated to congenital heart disease research. And so what that has meant is that Congress, through the National Health Institute, created the Pediatric Heart Network, which is a funded NIH institution or network through the NIH that guarantees certain levels of funding, I think upwards to $20 or $50 million of outlay for specific congenital heart research, both in the basic sciences and clinical sciences. So through our lobbying, especially in the last 10 years, we've been very effective at getting dedicated funds to address this problem, especially when we tell Congress that 1 in 100 babies is affected by congenital heart disease, and that's not changing. And our patients are now living to adults or to adulthood. They have been robust supporters. We would always like more, but they've been robust. And we haven't seen our funding streams changed since COVID. What's been very difficult is that we did have to shut down all of our research operations for about 4 months here at the Medical College of Wisconsin because of coronavirus, as we moved a lot of personal protective equipment from the research arena into the clinical arena. So labs were shut down from about March until June, and then were restarted in June. And we will see how the winter goes. We have a much more robust PPE situation at this point, so we don't anticipate labs being shut. But everyone is still, lots of people are still working remotely. It's been difficult to move things forward, but we are moving things forward.
All right. Well, I think those are the questions. So certainly, Todd, thank you so much for sharing with us this fascinating presentation. And I see that this must be a little helper you have.
It is. So this is one of my patients, Ryan. So this is a little boy that I treated with aortic valve stenosis as a baby, as a 30-day-old, and he's now 10 and still doing well. He had just had heart surgery to replace his aortic valve, but this was him back in clinic one day after his heart surgery. So he's a little buddy of mine.
Wow. Okay.
So, well, thank you everybody for sharing time with me. I appreciate it. Hopefully this opens some eyes and some thoughts about both what I do in congenital heart disease and makes people more aware, as well as you're thinking about how we can better take care of everyone in this country as we move forward. So thank you very much.
No, thank you. And I love that picture because it really shows, you can tell how proud you are of, I mean, you've changed that patient's life. And so it's obvious the important work that you're doing. So thanks, Professor Harper, for helping out with this. And of course to you, Dr. Gudowski. The academic theme this year at Illinois Wesleyan is Health, Healing, and Humanity. And this was a fantastic topic to include as part of a number of events related to that topic this year. So thanks for taking the time to share your stories and expertise and passion with the Titan community. We're also very proud of the work that you're doing. I hope you've all enjoyed this Back to College class and will join us for the virtual events coming up this weekend. At noon Central today, we will hear from Professor Scott Ferguson and David Rail to discuss the challenges of directing choral music this year. We are also hosting a virtual 5K and virtual golf outing, so I hope you're able to enjoy the beautiful weather and participate. Thanks to everyone who attended today. Stay safe, healthy, and vigilant. Go Titans.
Thanks, everyone.
Thank you.